Thank you for sticking it out with us and making it to the last session of the day. We sure do appreciate it. My name is Beth DeSantis. I'm a principal at HMA. I'm out of the Raleigh office, but I live here in Charleston. So thank you so much for joining us in Charleston and spending this day talking with us about the important healthcare issues that are going on in our state. And thank you for attending our first ever State of Reform here in South Carolina. So thank you very much. We look forward to having hopefully another one next year and the year after and the year after. So we hope to not have a hurricane interrupt our attendance. And we really are thinking of everybody who could not be here today because of the hurricane and everything that their family is going through. We are in for a real treat. Senator Davis is here. He is a man who needs very little introduction in our state because of how famous he is. So we are blessed to have him with us today. He's going to introduce himself and then do a talk, and then we're going to be able to ask him questions, of which I get to ask most. Okay? Okay, thank you. Senator Davis, I give you the floor.
Appreciate it, thank you. This giant timer down here says I got 39 minutes and 46 seconds. So what I'm going to do is talk for about 20 minutes and kind of outline some of the things that I'm working in regard to healthcare reform and markets here in South Carolina, and then leave the other 20 minutes for Q&A back and forth, maybe cover some things that I may not have addressed. But first of all, thank you for inviting me to speak to y'all. Over the last 5 or 6 years, there have been two subject matters in the General Assembly that have been most important to me. One is properly functioning energy markets in terms of generation of electricity for the grid. And second has been healthcare reform. And talking about healthcare reform is one of my favorite things to do because, and let me start out with this admonition. If we don't do something to improve the functioning of healthcare markets, I'm going to talk about that in a moment, how we can do that. If we don't do something about it or continue to do something about it in South Carolina, I feel like we're inexorably moving or sliding toward or slouching toward, however you want to phrase it, a single-payer system where people just throw their hands up in the air and say, this is just too darn complicated. We're going to turn it over to a bunch of individuals, give them a lot of authority, and let them regulate healthcare markets, which I think would be an absolute disaster for healthcare in the United States. And my party in particular, the Republican Party, historically has not been as proactive in this space as I think it ought to be. For too many years, we've been content to throw stones at the Affordable Care Act, at Medicaid, at Medicare, at other programs. Not to say that criticizing them hasn't been warranted, but it's also incumbent upon us as one of the two major political parties to offer up solutions, to offer up things that can make markets work better. And in my capacity as chairing the Healthcare Market Subcommittee on Senate Medical Affairs, I've dug into this for the past 5 or 6 years and trying to improve markets. And here's how I've approached it. I start with this premise that whenever providers of something are in sufficient numbers where there's competition, and whenever on the demand side, the users or the ones who use those services have choices, you get a better product at a lower cost. That market dynamic, I think, works across the board. When providers compete and consumers have choices, you get a better product at a lower cost. And we've historically really not applied that per se in the healthcare space, but I think it can be fairly applied there. And so the 5 or 6 pieces of legislation that I've gotten passed over the past few years in the General Assembly has attempted to improve those market dynamics. And let me tell you what I mean by that. On the supply side of the equation, making sure that we have a sufficient number of healthcare facilities and healthcare professionals to meet the needs of South Carolinians. And these are the constructive ways in which I've helped do that and working with great legislators like Mark Smith and others in the General Assembly to get it done. On the supply side of the equation, it's very important that every single medical professional be able to provide healthcare services that are commensurate with their scope, with their degree of competency. Scope of practice is the common phrase we use. And so if you do have a healthcare professional able to practice to their full degree of competency, that de facto is going to be increasing supply, and it's going to be increasing access. It's going to increase that market competitive dynamic on the supply side. And so what I found 6 or 7 years ago in addressing this are some non-physician healthcare providers, and I'll talk about physicians in a moment because they're obviously very important too at the top of the hierarchy. A lot of non-MD healthcare professionals were not allowed by South Carolina law to practice to their full scope of competency. One thing I didn't realize is that medical professionals can only do those things which the South Carolina Code says they're allowed to do. And if the South Carolina Code doesn't allow you to provide those services, whether you have the skill or whether you have the training or whether you have the ability, doesn't matter. And so what I recognized 6 years ago, maybe 7 years ago now, was that there was a disconnect between what the South Carolina Code allowed nurse practitioners to do and what schools were actually training nurse practitioners to do. And so, in other words, we never updated the statute over time, which was passed back in the 60s, so that what was statutorily permitted was commensurate and correlated with what nurse practitioners were being trained to do in schools. And so I filed a piece of legislation that synced up what the code allowed those NPs to do, or APRNs to do, with what they're being trained to do. And also in that legislation, I looked at a requirement that had also been on the books for over 50 years that said that even a nurse practitioner practicing within the allowed scope of competency could not render those services out of a 45-mile radius of where a supervising physician was located. And of course, that harkens back to the days where if a nurse practitioner had a problem and the physician had to help, he or she, the physician, had to get in a car and drive out to wherever that nurse practitioner was. Well, in today's day and age, we don't need that. When we have iPhones and telemedicine and ways to communicate, they weren't in place 50, 60 years ago. But that was the law. And as a consequence, since most physicians, not all, but most, reside in metropolitan areas, if you drew that 45-mile radius requirement from where those physicians were physically located, nurse practitioners could not get into rural communities to provide care at all because they were outside that 45-mile radius. And so 6 years ago, I drafted a piece of legislation and filed it in the Senate and got it passed through the Senate, got it passed through the House, and signed by the governor that, again, correlated scope of practice for nurse practitioners with what they were allowed, what they were being trained to do in schools, and removed that 45-mile radius requirement. And as a consequence, what you saw were nurse practitioners being able to go out into rural areas and really providing primary care to rural communities, sometimes for the first time. A lot of rural communities didn't have hospitals or physicians. And so that worked, seemingly worked. And so I did the same thing the next year with physicians' assistants. I mean, the same sort of thought process. Let's sync up their scope of practice allowed by law with what they're trained to do in school. Let's remove the 45-mile radius requirement. And again, let me emphasize, I am not advocating letting non-MD professionals do something that's beyond their scope of competency. That is not something that anybody would want to do. But by the same token, to the extent that they're able and competent to provide professional health care, they ought to be able and allowed to do that. And I think that helps with access, and it helps with competition, and it helps in rural communities in particular. We did the similar thing a couple years ago, and then I had to do some cleanup legislation this year. In fact, I think this was Mark Smith's bill, to further empower certified medical assistants to do certain things they were allowed to do. Because the more things that CMAs are allowed to do frees up a physician to provide the higher order of care and things that we really need physicians to do. And so, again, I look at it in terms of markets and supply and demand. And so far I've been talking about the supply side of the equation in terms of medical professionals and allowing them to practice to their full scope of competency, because that's good for competition and it's good for access. Also on the supply side of the equation, and I'll get to the demand side, the patient side in a moment, but also on the supply side of the equation are healthcare facilities, ambulatory surgery centers, hospitals, places where people can go and get care. And back in the 70s, and you probably already all realize this, but I'll provide some context for these comments. back in the 70s, Congress became convinced that the way to control healthcare costs was to require states to pass certificate of need laws so that there were healthcare administration at the state level that would monitor the investment of capital, and that anybody who wanted to invest capital to build a hospital or an ambulatory surgery center or anything had to go to Columbia and demonstrate need, get a certificate of need, argue that, in fact, this particular healthcare facility is needed in this community. And what Congress said was, we can't tell you to do this, states, but if you want to continue to get Medicaid and Medicare dollars, you have to pass a certificate of need law. Well, needless to say, 50 states passed CON laws because nobody was going to forego those Medicaid and Medicare dollars. A few years later, in the early 80s, Congress realized that restricting supply in that way, by really putting impediments in the way of capital investment for healthcare, wasn't the way to control costs at all. And they repealed that requirement that states had to have CON laws in order to get Medicaid and Medicare dollars. But by then, of course, you had 50 states that had CON laws. And more importantly, you had stakeholders in each of those states that now had an economic interest in making sure CON laws stayed in place. Because if you're a healthcare facility or a hospital that has that valuable piece of paper, a CON piece of paper, you like that. And you like the ability, if somebody comes into your neck of the woods and wants to build something to be in competition with you, you like that person or that entity has to go through a regulatory process. You like the opportunity to challenge that by saying, we don't need to have a new facility down here. We'll meet that need ourselves. We don't need to have competition coming in here. And in the event that DHEC disagreed and DHEC issued a CON to the proposed new entrant into the field, you could then appeal that decision in the administrative law courts and the courts and tie it up, in some cases, the testimony was, for over 10 years. And so as a practical matter, you really constrained the investment of healthcare capital. And it's a classic case. It's very difficult to repeal something. Once you have a law on the books that confers a benefit on a small group of powerful entities, okay, it is very difficult to repeal that law because they play in the political process. They contribute money to candidates. They contribute money in the community. They build up goodwill. It's very difficult to repeal something that benefits a small group of individuals because it's the classic case of whenever you confer benefits upon a small class and the costs of which are widespread and borne by the entire state, I mean, it's an unequal bargaining position. It's the former group that has the ability to lobby in Columbia. But we became, 2 years ago, I think 2 years ago now, right, 2 years ago, we became the 12th state in the nation that managed to overcome those obstacles and repeal the CON laws across the board, except for a 3-year sunset in regard to hospitals. And I wish that we hadn't had that, but we had to get something passed, and people had dug their heels in, and so we took what I consider to be 75, 80% of a loaf, and then in 3 years, we'll have complete CON repeal. And so I think that's an example of letting markets work on the capital side in terms of facilities, and so I think that's extremely positive. Now, moving to the demand side, it doesn't make any sense. If you increase healthcare access, if you build new healthcare facilities, and patients don't have the wherewithal to exercise those choices for whatever reason. And that's why I'm in favor of looking at everything that might empower demand, everything that might give the patients the financial ability to access these choices that we're providing on the supply side. And there's a long list of things we can do. But let's just go ahead and mention the elephant in the room here. One of them is, let's take a look at what would the consequences of expanding the Medicaid population as authorized by the Affordable Care Act. What would be the consequence? Now, I've been an opponent of expanding Medicaid, ever since it was part of the ACA. But what I've seen in the years since that was passed, because Medicaid has become synonymous, and to many extent, fairly so, with more federal control over the healthcare process. That the more that you get federal dollars in healthcare space, there are going to be strings attached to it that then empower federal officials and work against this whole market dynamic that I'm talking about. But what we've seen in recent years are a lot of conservative states, a lot of Republican states, solidly red Republican states, have elected to expand their Medicaid populations because the CMS has become increasingly willing to not provide as many restrictions on the use of those dollars, or letting states do innovative and creative things with those dollars, and not usurping state policymaking roles as a result of putting more money into the healthcare system. So I think it's at least worth studying whether or not expanding Medicaid, as authorized by the ACA, would be a net positive for South Carolina. Now, I go into the debate with serious reservations and questions, okay? First of all, for the first reason I said, I don't necessarily like the federal government having a heavier footprint in regard to monies being put into healthcare policy, because as a rule, with money comes regulation, and I'm not in favor of more federal regulation at the state level. But by the same token, we deserve to talk about it. We have to have a debate about it. We can't just simply chalk it up to something that was passed by a Democratic administration, and therefore it must be a bad idea and we shouldn't consider it. It is our job as representatives of the people of South Carolina up in Columbia to debate all these issues. And when you're talking about making markets work better, you can't just focus on the supply side, which I've done. You got to look at the demand side and have an honest debate about whether or not this would improve things. Now again, I've got some, and I pause for a smattering of applause. So I will say that I want to have that debate. I think that the people of South Carolina deserve to hear that debate. One of the practical political problems of this, though, and I'll just be frank, is that it's an easy issue to demagogue. It's an easy issue to point to and say, this fellow here is for Medicaid expansion, therefore he's in favor of more federal control over healthcare policy, therefore he's in favor of single payer, and we don't want that because we don't want socialization of medicine in South Carolina. Very easy issue to demagogue. It is a harder issue to then speak in paragraphs and explain why that's not what you have in mind, and how counterintuitively, how it actually might help markets work and stave off this slide towards single payer, which I think we're moving towards. So I want to have that debate. I have reservations about it, and the last reservation I have about it, not the last one, but another important one is, we're almost $35 trillion in debt in the United States. We have structural annual deficits of over $1 trillion, and we have zero political will on either the Republican or Democratic side to do anything about that financial situation. I hate to say this, there is going to come a point where there is a bad financial reckoning, and either we can't go out into the bond market and we can't sell the bonds at the rates that we want to, or for whatever reason bondholders may decide not to renew their bonds. That's coming at some point in time. And a state that is heavily reliant upon federal dollars, when that financial Armageddon comes, has a much more difficult, climb out of that hole. So I don't want to leave you under any illusions that I'm standing here right now, because I'm not, saying that I'm in favor of expanding Medicaid in South Carolina. I have serious reservations about it. But we can't have a comprehensive debate about the supply side and the demand side and what might make markets work better without having that conversation. So that's the second thing I'll say about demand. A couple of ancillary things I'm going to say about the importance and the primacy of the physician-patient relationship. That's the bedrock upon which I think all other healthcare policy flows, is that particular relationship between the doctor and the patient. And so every chance I get, I try to promote that particular relationship up there. I've been a big champion over the years for a very tightly regulated medical marijuana policy in South Carolina, because if a physician believes that one of their patients with Parkinson's or a neurological disorder or chronic pain might benefit more from marijuana than they would an opioid, why not let that physician do what's in that patient's best interest? What business do we have as politicians as saying, these are the things that you can consider giving to patients, but despite your training and despite the trust we have in you, we're not going to give you this option. To me, that doesn't make any sense, especially when over the last 40 years, there is a well-developed medical research that marijuana or cannabis can be efficacious in a whole lot of areas, and chronic pain being one of them, where we rely upon a lot on opioids right now. Very therapeutic as well in regard to neurological diseases, because there are things about the cannabinoids in marijuana that interact with the body's cannabinoidal system and addresses the underlying problem of a lot of these neurological disorders. You've got 39 states that have recognized this and have medical policies. What I've been proposing over the years is an extremely tightly regulated, conservative medical marijuana program that only has like 9 or 10 qualifying conditions. And the only conditions are those for which there is peer-reviewed studies saying marijuana can be efficacious. Not anecdotal studies, peer-reviewed studies. So there's a limited number of conditions. It has to be authorized by a physician. It has to be supervised by a physician. It has to be dispensed by a pharmacist. I mean, so it is so conservative now that a lot of the grassroots, no pun intended, out there don't like this because they don't like filling this space with a very conservative policy. But I frankly think that's where South Carolinians are. I think that they want to empower doctors, they want to empower patients, they want to give them those options, but they don't want to put us on a slippery slope to recreational use. That is my assessment of where I think most South Carolinians are, and that is one way in which I'm trying to promote the primacy of that physician-patient relationship. One other area, and then I'm almost to break my rule, I'm 15 seconds away from 20 minutes, but declaring void as a matter of public policy non-compete agreements between hospitals and physicians, I think, is important and critical. For the same reason that it's against public policy for a law firm to lock down an attorney, okay? Because the best interest of that client might be better served if that client goes elsewhere and the attorney goes with him, or if the attorney leaves and starts out on his or her own. Why not let that client follow? I mean, non-compete doesn't make any sense if you want to promote an attorney-client relationship. It doesn't make any sense if you're looking after the primacy of a physician-patient relationship to say to a patient, if a physician decides to leave, you can't follow this physician because there's a non-compete clause. I just don't think that makes any sense. So that is something that I know that I'm going to work on next year. I suspect Mark will as well. To provide economic freedom in regard to physicians moving into that particular space. So, okay, I've been talking for 20 minutes. That's a thumbnail sketch of some of the things that I want to work on to improve markets. I hope I've given somewhat of a reason, for how I approach these issues and how I look at them. But maybe some stuff will come up during the Q&A. Thank you all.
Thank you, Senator Davis. It's wonderful having you here and listening to everything you've been doing in the past. So thank you for everything you've done, especially for the scope of practice. That's been great. I'm a nurse practitioner by training, so thank you. I took that very personally.
And I make this qualifying comment too, because I've spoken in favor of expanding scopes of practice. And this battle is going to go on next year between ophthalmologists and optometrists. It's going to go on with nurse practitioners wanting independent practice authority. I mean, so what I look at is this. On the one hand, by increasing scope, you increase access. But at some point in time, you can increase scope to where you're endangering patient safety, okay? And so for me, if the danger to the patient is materially increased, like for instance, anesthesiologists, I mean, if something goes wrong there, a patient might die, okay? And that's a lot different than some other areas where I might address scope issues. So looking at, I want to be fair, that there are scope requests that I've turned down, and I have simply said to applicants, I understand what you're saying about you want this to work in this area, you want to be in this space, but I think that the damage being done to a patient's health or the threat of damage to that patient's health is too severe, so I can't be supportive of expanding scope in that context. So it works both ways. It's a balancing act that you take on a case-by-case basis, and you just have to ask a lot of questions. And as a non-physician or a non-medical person, being humble enough to understand that you have to learn. I mean, and there's research you have to do and people you need to listen to. So.
Thank you, that's great. You did mention some fights that were coming in the next legislative session. Can you kind of help us understand what's coming and what we should be aware of?
Well, the big one is going to be, not the big one, a big one is going to be nurse practitioners and physician's assistants not only wanting the authority to provide care within their scope of competency, okay, which we got done. I passed legislation a few years to do that. But they're saying that so long as we're practicing within our scope of competency, why do we have to have a supervising physician that we share fees with? Why can't we, if we're acting within our proper scope and we are qualified to provide a certain amount of care because of the schooling we've had, why is it that we still have to have a practice agreement with a physician and whenever we get paid, split the amount of money with the physician? That's coming up. And so I'm going to have to tackle, with an open mind, I'm going to have to tackle whether or not is this going to increase access? Is it going to increase mobility for these non-MD practitioners? Is it going to result in lower prices? Or on the other hand, is it going to result in a risk to patient safety because you're not going to have a physician that is obligated through a practice agreement to oversee and be responsible for any negligence done by that nurse practitioner. So there's a lot of issues to unpack here. But I think that those two bills are likely to travel separately. I think the independent practice for nurse practitioners will be a separate bill. Independent practice for physicians' assistants will be a separate bill. They'll both come to my subcommittee on medical affairs because I handle scope issues, so that'll be one. The next one will be the battle between ophthalmologists and optometrists. And optometrists, on the one hand, are going to make the argument that we're trained to do more things now in optometry school. There are more things that we can do, in regard to things that are invasive to the eye or actual surgery to the eye that we're allowed to do under state law. We're not competent to do. We want that authority because it will increase access for patients and it will drive costs down because there's more competition. The ophthalmologist will counter by saying, you're dealing in an area here where if something goes wrong, somebody loses their sight. The consequences of malpractice are severe, therefore patient safety ought to be the paramount consideration there. That's also going to be a very contentious matter between those two particular medical groups, I think.
Great, thank you.
And nurse anesthetists and anesthesiologists are going to go after each other as well. I mean, the nurse anesthetist will make the argument that we can provide this care without a supervising anesthesiologist. Anesthesiologists will make the argument that if something goes wrong, you want to have a physician there. I mean, or the patient can lose their life. So that's going to be a contentious area as well. So, but again, the best I can do in sort of like addressing these matters and looking at legislation is to discuss the prism through which I look at it, okay? And I look at it on the one hand, does it increase access, but does it increase access in a way that really jeopardizes patient safety? And you do the best you can to try to balance those two things based on the facts.
That's great, thank you. I also understand you're interested in technology's application in the healthcare setting. Can you talk a little bit about that?
Yeah, we just updated and modernized our telemedicine protocols because I think increasingly, and COVID really accelerated this trend that was already occurring of people becoming more comfortable consuming their medical services online or through telemedicine rather than in person. So I think that as markets and as consumers become more comfortable with that medium, I think that we need to take advantage of the technological ways in which physicians can interact or other medical professionals can interact with the patients. And again, it's like with scopes of practice. And this is what makes the practice of medicine, as a public policy matter, complicated. You can only do things via telemedicine to the extent state law allows you to. Okay, and so once you pass a state law allowing a certain form of telemedicine to take place, in 3 or 4 years, because technology has exponentially improved, you got to go back and revisit to make sure that we are allowing medical professionals to utilize that technology. So I think that's going to be an issue. Another ancillary issue to that is, as the practice of consuming medical services via telemedicine becomes more and more accepted, there is increasing pressure to open up South Carolina's borders to medical professionals in other states and allowing medical professionals in South Carolina to treat patients in other states because, of course, if it's telemedicine, it crosses state lines. And so, again, there's a whole host of policy considerations associated with that. I mean, states like to control their medical policy and their standards, and there's a reluctance to cede sovereignty over that area to a consortium of states, these compacts that are formed. But on the other hand, if you're looking to expand supply and provide patients with more choices, this is certainly a way to do that. So, again, all of these issues are extremely complicated, and I try not to talk about any of them in absolute terms because the proponents and opponents of each of these things have good arguments to make, and it's important to go into it with an open mind and then strike the best balance you can.
That's great. I'm going to ask one more question, and then we're going to open it up to you guys just to make sure you have a chance to ask a question. So building consensus on any issue in the legislature can be challenging. You've been very successful. What are the things that you have done that have made your work so successful?
I've really worked hard with establishing relationships with House members like Mark Smith, who is an emerging leader in this space. Just relied upon very heavily in the House. To have a great relationship with somebody like Mark is important. But going to the Speaker of the House, for instance, and every year I'll go to Merle Smith, or last few years, and I'll say, all right, Merle, what are your priorities for this year? What sort of things do you want to see accomplished? And what can I do to help you move your bills over in the Senate? Where's your opposition? Where do you think your opponents are coming from? And if you reach out in that way and you have respect for what somebody else's objectives are, that you usually see it being reciprocated when you've got something that's important to you and you think you've made a valid case. Because believe it or not, just simply having a good argument and a superior case being made doesn't mean your legislation becomes law in the General Assembly. And relationships are extremely important. And it's going to be important in any democratic process. Things only get passed if you get a majority of the 124 members of the House and a majority of the 46 members of the Senate. And it's not going to get by just on the merits of what you propose. You have to have relationships. You have to be open to what's important to somebody else and how can you help them. So I've focused on that. And sort of in my practice, I'm an attorney, but I'm not a litigator. I'm what is now called a transactional attorney, which means a fancy way of saying I don't get into court. But I draft complicated commercial transactions, corporate work, things of that nature. And in that space, the only success is if there is a closing and funds are dispersed. It doesn't matter if you make a brilliant argument on behalf of your client if the deal falls apart. So I feel like, my skill set lends itself to sort of finding what is that ground where each party's needs can be met. How can we move the ball forward and address not only one person's issues but another? I don't like this tendency in politics of a zero-sum game, that what you want to do is vanquish the other side, that the other side's the enemy, that what you pass has to be 100% of what you want and they don't have anything constructive to offer. I don't think that's healthy either. And so I think having a transactional, in the terms of the way I've just described it, is important in complex legislation because complex legislation is never black or white. It's shades of gray. And the ability to listen to both sides and then move the ball forward for South Carolinians, because after all, we're here not to win for Republicans or win for Democrats. We're here to make lives better for South Carolinians. And so if you approach it with that mindset, as I try to be, I think you can have success.
That's awesome. Okay, I'm going to get up, and if you would like to ask a question, if you could just raise your hand, I'll come to you. Oh, good, thank you, right there. Right behind you.
Oh, it's behind me. I just want to say thank you for your openness to consider the expansion of Medicaid. I know it's complicated in South Carolina. I've lived here my whole life. But as a social worker, I look at it through the lens of what's best for the citizens and the human side of it. So thank you. It is refreshing that you're willing to look at it and you're willing to see both sides. So I'm most grateful for that.
And one of the things that my colleagues, and I'll just speak for the Republican side of the aisle for a moment here, is that in the decade or so, however long it's been, when was the Affordable Care Act? Passed in 2010? Is it 2010? so 14 years, however long it's been. It is not the same program that it was back then. Otherwise, you would not have seen several Republican states in recent years decide to expand what the Affordable Care Act allows you to expand, because the CMS is willing to give more waivers. The CMS is willing to provide the money without the strings dictating how you spend it. So we at least have to have a discussion and educate them as to how it has changed over the years. And I think what people need to realize as well is if we don't take the money, and it could be in excess of $1 billion a year that could come into South Carolina, it doesn't go back and pay down the debt, okay? It gets divided up among the states that do participate in Medicaid expansion. So on the one hand, I might like to say, I don't think this is something we can afford, and this might help us, control our deficit spending. It might help pay down the almost $35 trillion debt. But the reality is the money just gets divided pro rata among those states that have expanded it. So I think having that conversation, though, look, conversation is always good. I mean, having arguments is always good. And this tendency now to demagogue things and to try to put something on a bumper sticker and point to somebody and say, he is in favor of creating a health czar here in South Carolina and turning all of our power over to somebody up in Washington, D.C. I mean, that isn't an argument. Let's have an argument. Let's debate the merits and the demerits. And look, if it turns out, as I suspect it might, especially given the makeup of the General Assembly, that we decide not to do it, I can live with that result. What I can't live with is refusing to have a debate, refusing to debate ideas, refusing to answer tough questions before you make that decision.
Great. Hey, Senator, appreciate your comments today. I was thinking about how you were talking about certificate of need and the free market. And I certainly appreciate being able to drive competition. But one of those prerequisites for an effective free market is an educated consumer, right? I know that the car that I want, this Ford dealership, it's $1,000 less than that one, so I'm going to choose this one. But I would say healthcare today predominantly seems like it's a sign on the dotted line. In 30 days, we'll tell you what the price was that you agreed to pay. And if you don't sign, you'll die. Right? So do you have any initiatives, is there anything before medical affairs to try to increase price transparency or better empower the healthcare consumer so that a free market can actually potentially lower prices through competition?
That's an excellent point, because markets will work only if proper price signals are being sent to consumers, and if consumers have the ability to compare apples to apples and shop intelligently. And right now, you just can't do that in the healthcare space. There are so many hidden fees, hidden costs that a consumer wouldn't know what to do in regard to. I mean, it's not like going to a grocery store right now and figuring out, okay, who is selling milk at this price and milk at that price. They know how to do that. To empower the consumers in the way that I want to, there has to be price transparency. There has to be a correlation between a price being offered for a particular service by one medical establishment compared to another, or it's not going to work. And I could argue this by analogy in the energy sector as well, but across the board, because as a conservative, okay, and as someone who believes in markets, I try to approach it from that perspective, increasing supply, empowering demand. But if you don't have proper price signals, to your point, you can't have an educated consumer. And if you don't have an educated consumer, then it's not going to work. And we might as well just turn the keys over and let it be controlled by some central authority. I'm not willing to give up on that yet. I'm not willing to give up on that. I do think that individuals, if you give them a mechanism to be able to intelligently shop and to price, I think we can get them there. But we ought to be focused on educating and letting them know that there are alternatives, and this is the best way to assess those alternatives, because you're right. If there's not a proper pricing procedure, it won't work.
You have another question?
We got 1 minute and 53 seconds left.
Yep.
Let me ask this question. Okay, got another question.
John?
Thank you, Senator, for being here, and thanks for your transparency, too. In thinking about the similar circumstances in our neighbors to the north, in North Carolina, what they've gone through, they kind of looked at expansion in bite-sized chunks before they got there. You know, they started out with reform and managed care, then they looked at Medicaid waivers to figure out how to deal with more access to care, And then they talked about, the remaining populations that are left. Have you talked to anyone up there, like Senator Bergen, Senator Kravick, just to learn from that experience as you start engaging your colleagues in this conversation?
To a limited extent. And the way that North Carolina got their Medicaid population expanded is they coupled it with CON repeal. Okay, so the way they packaged it up there was, okay, free market conservatives, we're going to repeal certificate of need, and we're going to allow competition in this capital space. On the other hand, we want you to go ahead and expand Medicaid. And so it was really a bargain struck between Republicans and Democrats in North Carolina to make that work for Medicaid expansion. We got CON repeal done here in South Carolina straight up. We didn't have something added to it. So from a strategic standpoint, it's difficult because it's just different. Up there, it traveled together. But I think we can learn from our neighbors to the north in North Carolina. Look at what their experiences are. Have we seen better health care outcomes? Do we see patients that are empowered and able to go ahead and access health care in a better way? I mean, I think it gives us an example of looking at a southern state, a sister state, and seeing what their experiences are. And that's one of the best things, one of the great things about living in the United States is we've got 50 laboratories of democracy, right? We got 50 states, and we can look at what other states have done and see what works and not necessarily reinvent the wheel. And so that is, to your point, one of the things we should do is engage with our colleagues to the north, find out what their experience with expanding that population has been, what have been the unanticipated consequences, what have been some of the benefits you didn't expect. And hopefully that informs our debate down here. But again, that presupposes that leadership here in South Carolina will allow us to have that debate here in South Carolina. And I think we have to have it. I included it in a budget proviso that was in this year's budget. We were going to study the issue, but it got vetoed by Governor McMaster, so it didn't happen. But I'm going to try it again next year. Well, now we're at 0.
Yeah,
so what does that mean?
We're out of time.
Okay, we're out of time. Well,
But thank you so much, Senator Davis.
Thank you all for letting me talk about these things. It's a good way for me to start organizing my thoughts for January and to start prioritizing things and to anticipate what's coming, drafting legislation. Again, energy and healthcare are the two most important subject matter areas, in my opinion, that we have to tackle in the next 5 years. And so I'm in the middle of both those debates. It's part of what I love about serving in the legislature. I know Mark appreciates this too, is being able to dig into something that actually impacts people's lives and then make them, improve them for the better. So thank you all for having me.
Let's give a round of applause. Thank you.